So this we're now moving to actually not very far away from the previous session. We're moving now to let's say more critical patients or decisions, either in the emergency department, either in the ICCU, and we have an amazing faculty for dealing with 3 different situations or management decisions this afternoon. So I'm with Alessandro again, so he will introduce the first speaker.
It's a pleasure for me to introduce our first speaker. It's Dr. Susanna Price from the NHS Royal Brompton and Harefield Trust. She is a cardiologist and intensivist. She's been working with very sick patients during her whole professional life, and she has a special interest in imaging, in critical care, and I will also tell, by the way, that she is a very good friend of many Spanish cardiologists that are at the moment in the audience that have been able to benefit from all teachings. So Susanna, it's a pleasure to have you here. Go ahead.
Okay, thank you very much for the invitation. And my unenviable title was Everything Cardiologists Should Know About Echocardiography in Critical Care, which I'm supposed to deliver in 30 minutes. So I changed the title to Critical Care Echocardiography, What Every Cardiologist Should Know. And I'm going to try and take you through the approach that we use on our ICU when we're using echocardiography to evaluate the critically ill patient. So if you were to come to the Royal Brompton Hospital some years ago, it would have looked like this. But as you know, property is very scarce in London, and we sold this bit of the Brompton, and now it looks like this, which is not like beautiful Spanish architecture, but it's very functional. And if you come to visit us, and anybody would be very welcome, this is where the Brompton is, and it's nice and central. So the Houses of Parliament are around here, and Buckingham Palace is up here. So please feel free to pass by at any time. The first thing I have to ask myself is why echocardiography in critical care? And I think it's a simple thing to answer. It's immediately available. Transferring patients elsewhere is not without risk. There are significant mortality and morbidity risks to transferring the critically ill patient. And if we use radiation in our ICUs, it puts our nursing staff at risk. So echocardiography is really the investigation of choice if we're looking at the heart. And if we look at the literature, although it's a small proportion of what is published in terms of echocardiography overall, the numbers of publications related to critical care echo are definitely increasing. If you look at the concept of acute cardiac care, so you're looking at cardiac care in effect without walls, we're there looking at echocardiography in the pre-hospital setting, the emergency department, the acute medical setting, the intensive care unit, and also in the operating room. So the potential scope, if you look at all the individual syndromes, is absolutely massive. When I look at the way I use echocardiography on my ICU, I either use it as a monitor, so you can measure cardiac output if you're so inclined. You can look at it to evaluate physiology, so this is a nice study looking at surrogates of isovolumic relaxation time to estimate left atrial pressure. You can look at it, use it to look at perfusion, and you can use it to look at anatomy. But despite that, if you look at the literature, the vast majority of requests in intensive care are what is the ventricular function or what's the ejection fraction. And I'd just like to explore the utility of asking that question with you for a moment with 3 examples. So on the top left, these are all patients who came through my ICU. So on the top left, there's a patient with a univentricular heart. She had truncus arteriosus, she had endocarditis, she was clinically in a low cardiac output state despite inodilator support, and the question was, what's her ventricular function? The second patient was a 52-year-old teacher who had had cardiac surgery, a revascularization and an aortic valve replacement, and they were on a significant amount of support, so a left ventricular, right ventricular assist device, a balloon pump. They'd been loaded with levosimendan, and the question was the ventricular function any better? So you can see the echo there. And the third one was a patient who was admitted with breathlessness, had a critically low cardiac output state, had a cardiac index of 1.1 litres per minute per metre squared measured by pico, and this was his echocardiogram. And I think the most important aspect of intensive care echo is actually asking the right question and answering the right question. So with those three patients, the first patient with the truncus arteriosus and the univentricular heart and the low cardiac output, the question is, what can I do to manipulate the circulation of this patient to give them a survivable cardiac output? That's the question. It's not, what is the ejection fraction? The second patient, who was on the left ventricular, right ventricular, balloon pump and loads of inotropes, it's not, again, a question of what is the ventricular function. It's how do I progress this patient forward? Which type of support can I lose? And how do I support the heart whilst we're doing that? So which inotropes or pacing therapy should I use? And the third patient with a cardiac index of 1.1 and in cardiogenic shock, actually the question is, as this patient has a cardiac index that is incompatible with survival, is there anything I can offer that would suggest how we could improve the cardiac output and index? The actual number for the ejection fraction is irrelevant. So the key things as a cardiologist, what is it that the intensivists want to know? What is it that you think that they should know but they haven't asked? What is the ejection fraction actually is irrelevant. And the next most important thing is what is the clinical context in which you find yourself. And we all know that echo in the ICU can be challenging. So these are pictures not from England but from Italy. So the intensivist was asked to do an echo, a transthoracic echo on this patient. Now I would challenge you to get high quality images. This patient, there was a question whether they could have a transesophageal echo, and clearly with that degree of skull trauma, it is not appropriate to undertake a TOE. There are problems with image acquisition related to the pathology that presents to us. So these were patients that presented to us during the 2009-2010 H1N1 pandemic, and it is very difficult to use echocardiography to image when you have that degree of surgical emphysema. There are things that the intensivists do that make our lives difficult. So this is a patient where somebody was asked to do a transthoracic echo. It is not impossible to do a TTE with the patient prone, but it is challenging and you need to know where your echo windows are. By contrast, they asked for a transesophageal echo with this patient on a CPAP helmet, impossible and actually probably contraindicated. And in the patient on the right, it's almost impossible to get to the patient because there's that much kit around the bed. So there are challenges. There are also challenges that may be temporal in position. So the guidelines that we now have, the ILCOR guidelines from 2015 and 2010, both mentioned echocardiography and cardiac arrest. And then you're going to get your information is limited to the 10-second pulse and rhythm check. No more than that. You cannot interrupt your ALS algorithm. Or similarly, you may find a patient who's profoundly shocked, and you're not going to want to spend 25 minutes doing a comprehensive echocardiogram before you start trying to solve that patient's hemodynamic status. Finally, you have to think in terms of the clinical context of what about the pharmacological milieu of that patient and what kind of support are they on. So what is the inotropic status? How filled are they? Think about the effects of sedation on myocardial function. Every sedative that we give on the ICU is a negative inotrope to a greater or lesser extent. Think very carefully about the metabolic status and some of the newer tolerances, may I say, in intensive care of permissive hypercarbia or tolerating relative hypoxemia can have very profound effects on the right ventricle. So make sure you look at the arterial blood gases before you approach the patient, and then mechanical, circulatory and extracorporeal respiratory support bring with it their own challenges. On top of that, you then have to think about the differential effects of the right and left heart, the effects that the ventilatory maneuvers may have on the right and left heart interaction, and then put on top of that the fact that we mostly don't know the normal values in the critical care setting. It gives us a challenge, but when you approach the patient, have all of these things in mind. The next thing I think is probably the most important. So what is the diagnosis? Just being critically ill or having cardiogenic shock or heart failure is not a diagnosis, it's a label. And you need to know what the diagnosis is. So this is a very simple one. This is a patient who was on our HDU having had cardiac surgery. They had a transthoracic echo done by a cardiology trainee on the ward. The patient clearly was not well. They had a base deficit of -17. They had oliguria and they were in a low cardiac output state. And this was the transthoracic echo that the trainee obtained. And they said there were no features of tamponade, and the patient was transferred to the ICU. On the ICU, we did a transesophageal echo, and you could see there was a huge pericardial collection that had been completely missed on the transthoracic echo. So when you take with you to the ICU your preconceptions of how you diagnose a particular condition or syndrome, you have to understand that sometimes in intensive care the literature is different. So this is just one example of a number of papers, but if you go to the literature and look at the diagnosis of tamponade following cardiac surgery, if you rely on TTE and your standard echocardiographic parameters, you will miss round about 50% of them. So you need to know the literature and you need to know the limitations of echo in context. And this is illustrated further just by a series of patients that were referred to us for various interventions. So on the top, all three of these patients, they're three different patients, were referred through our national ECMO network for severe acute respiratory failure. They'd all had echoes done at the referring hospitals, and it was felt that the respiratory problem was the primary diagnosis. This patient had trisomy 21. They had a secundum ASD, but they also had a primum ASD and a VSD. So they did not need to have ECMO. This was a 42-year-old man who had reportedly a normal transthoracic echo, but poor views because of the extensive pulmonary edema, which had been labelled mistakenly as pneumonia, and he did very well with mitral valve surgery. And I'm giving you an old-fashioned M mode of a gentleman who came to us having been ventilated for 6 weeks in another institution and was reportedly unable to wean, and he'd had a previous mitral valve replacement. And just with the first image, the echocardiographer was able to say, well, this septal motion is normal, this LV function is too good, and transesophageal echo confirmed the patient had paraprosthetic regurgitation, and he did very well with redo mitral valve surgery. In the middle, we have patients with a so-called easy assessment of volemic status. This was a 17-year-old patient with a Ewing sarcoma who was put onto the operating table and promptly arrested when he was laid flat. And the left ventricle looked very empty, so they kept giving him more and more volume. The problem was not that he was hypovolemic. The problem was, this is his transesophageal echo, that on lying him flat, he had kinked his right upper pulmonary veins. So there was no venous return from the ventilated lung, and the lung that did have venous return was not being ventilated. So we simply repositioned the patient, and he went for some very urgent chemotherapy prior to surgery. This patient was on veno-venous extracorporeal membrane oxygenation. The patient was going into cardiogenic shock. The ejection fraction on the left side was reportedly improved, and the reason was that the right heart was failing quite profoundly, and she needed upgrading to VA ECMO. At the bottom, we have a patient that was referred to us apparently with isolated coronary disease and a normal mitral valve. They underwent percutaneous revascularization, transesophageal echo. The patient is on ECMO. You can see that the heart is not ejecting, revealed that they'd ruptured their papillary muscle. And that's why they were so unwell. And the bottom right, another patient referred for failure to wean. Why did they fail to wean? They had significant interventricular dysynchrony. So in all of these patients, the key was making the diagnosis. They all had a low cardiac output state, but the treatment and the intervention were profoundly different. Okay, so the most important thing, having made the diagnosis, the next question is, how is the patient being sedated and ventilated? If you walk onto the ICU, you'll see the ventilator next to the patient's bed. There are lots of fancy ways to ventilate the patient, and we all know as cardiologists that during delivery of a positive pressure ventilated breath, the flows in the right heart fall and the flows in the left heart increase. But ventilation is much more complex than that, and there are two phases, both to the intubation and ventilation, and also then to the subsequently weaning the patient. And this will be one of the commonest reasons you'll be asked to go to the ICU. Between 3 and about 80% of patients will have difficulty in weaning, and you may be asked to discern whether there's a cardiac component. And to do that, you need to understand what happens on weaning and extubation. So the cardiological impact of weaning in terms of just reducing sedation relates to not only the increased work of breathing and the redistribution of the blood flow to the muscles of respiration, but also some significant hemodynamic changes. And the second phase, which is extubation, represents a significant stress to our patients. If you measure their endogenous catecholamines, they're increased, and if you bother to calculate the rate pressure product, it will increase quite significantly. So in a patient with ischemic heart disease or borderline cardiac function, this can be a very challenging state. We read about the effects of ventilation, and you may ask yourself whether it's really relevant or whether it's just something you see in the textbooks. This was a patient of ours. She'd repeatedly failed to wean, having gone into pulmonary edema. Transthoracic echo had shown mild mitral regurgitation, which on the surface of it looked to be confirmed using transesophageal echo. But the person who did this echo knew that sedation and ventilation is a good treatment for mitral regurgitation. So with a 100 ml fluid bolus and enough pressor to get the systolic blood pressure up to about 100 millimeters of mercury, I shall show you what happened to the mitral regurgitation. She developed catastrophic mitral regurgitation, and this is what had happened to this patient every time she tried to wean. So when you're asked to approach a patient on a ventilator, ask yourself, what question are they asking? Failure to wean or hemodynamic instability, and try and mimic the physiological status at which that patient has difficulty. What about the right heart? So ventilation can be good in terms of left heart pathology. The right heart pathology, we all know, we've been taught it for many years, that it can be very bad. This is an old study from François Jardin and his colleagues looking at simultaneous left and right ventricular pressures with 0 PEEP and then a PEEP of 20. So positive end expiratory pressure of 20. And you can see with this quite aggressive amount of PEEP, transiently at end systole, the right ventricular systolic pressure exceeds that of the left. And that's shown by the abnormal movement of the interventricular septum. So that's quite a gross change. What about more subtle change? So this is non-injurious ventilation, a patient who's about to go whole lung lavage for pulmonary alveolar proteinosis. And this is non-injurious ventilation. It's very conservative ventilation. You can see there's an acute change in the dimension of the right heart with positive pressure ventilation, and a very dramatic change in both the tissue Doppler imaging and the systolic motion of the long axis of the tricuspid annulus. So you get very acute and sometimes subtle changes in right ventricular function that may be important to our patients. Ventilation, we're taught, is bad for the right heart because it increases right-sided afterload, but so does hypoxemia and so does hypercarbia. So have a look at what your pulmonary flow looks like. This is a very short pulmonary acceleration time consistent with a high PVR, and with these various very aggressive interventions, you can see the stroke distance from the right heart improves significantly, the right ventricular systolic function improves, and the pulmonary vascular resistance has dropped. So don't just use simple things like tricuspid regurgitation velocities for pulmonary artery systolic pressure. Think about the pulmonary vascular resistance as well. And moving to even more subtle changes, we know from the pediatric literature that the right ventricle can become restrictive, and to define a restrictive right ventricle, you want to see a forward or pre-systolic A wave in the pulmonary artery distal to the pulmonary valve. That's restrictive right ventricular physiology, where it's felt that the right ventricle becomes in effect so stiff that when the atrium contracts, that forward flow of blood is transmitted directly into the pulmonary artery. Do we see it in adult intensive care? If you go looking for it, yes, you will see it. We see it in around 43% of our critically ill patients, and it is important because during delivery of a positive pressure inspiratory breath, you will abolish that forward pre-systolic A wave. And in a patient with a very borderline stroke distance from the right heart, that may lose you around 22% or up to 22% of your forward stroke volume. And in combination with that, during delivery of this positive pressure breath, you will see retrograde waves going down the SVC and the IVC. So you're intermittently giving that patient a low forward stroke volume and a high venous pressure, which is not a good situation to be in. So very finally, what about the left atrial pressure? We're all taught in the echo lab that these are the parameters that we should use, but everything changes when you ventilate the patient, and you should know which parameters you should use to try to estimate the left atrial pressure and in which combination, and this is a very excellent paper from the French intensive care group. Always be very careful though. When you look at your transmitral Doppler, so this is a patient who went into the emergency department clinically and radiographically in pulmonary edema. And you would expect her to have a dominant E wave on transmitral filling, and she does not. So when you don't see what you expect, always checked internally. She has very prolonged contraction with post-systolic shortening on the long axis of the mitral valve. And this was seen in the circumflex territory. This was her coronary angiogram. And when she was revascularized, her transmitral Doppler went from this to what you would actually expect for that patient. So always check for internal consistency. If you see something that doesn't fit, go back and ask yourself why. One might argue that maybe we should really be looking to the lungs if we're thinking about pulmonary edema. There is emerging evidence to suggest in the diagnosis of pneumothorax and interstitial edema that lung ultrasound is superior to chest radiograph and may be equivalent to CT. You want to see, if you're looking for pulmonary edema, this homogeneous B-type pattern, which correlates reasonably well with levels of natriuretic peptide, but may also allow you to see concomitant pathology. So here is a patient who you can demonstrate directly the ventilation mismatch. So this is non-ventilated, consolidated lung, and this is perfusion. So here you can see the VQ mismatch, and you may be able to see dual pathology simply using ultrasound at the bedside. And finally, what about the heart rate? This is something we don't think about enough in intensive care. We all know as cardiologists that in the absence of coronary disease or ischemic heart disease, the duration of systole is relatively fixed. And the duration needed for diastole depends upon the pathology. So here you have a patient with a restrictive left ventricle that doesn't need much time. Here you have a patient with mitral stenosis that needs a lot of time to fill the ventricle. So obviously the optimal heart rate for each patient will vary. The AV delay optimal will vary, as will the VV delay if they have dysynchrony. You can measure this very simply at the bedside by measuring the total isovolumic time, so the time that the heart is neither filling nor emptying. It should be below 14 seconds in any 1 minute. It's abnormal in up to 23 to 45% of patients on ICU, depending on the type of ICU you're looking at. And if you minimize the total isovolumic time, you can actually significantly increase the stroke volume of your patient without using inotropic agents. So this was just a pilot study that was done by Guido Tavazzi on our unit, and he looked at the total isovolumic time for the left heart and the cardiac output, and looked to optimize heart rate, cardiac output by using heart rate and minimizing the total isovolumic time. And with no change in inotropes, he was able to get a mean increase of cardiac output of 2.2 litres per minute, a mean increase in cardiac index of 1.2 litres per minute per metre squared. So a significant increase just by looking at the pacing at the end of the patient's bed. And we know in the longer term in cardiac patients that TIVT correlates with mortality, follow-up events, cardiac events after cardiac surgery, and the patient's exercise capacity. It's very simple to do. You can also look at TIVT by resynchronizing the left heart if you have the beauty of having biventricular pacing. And again, in a pilot study, and we're following this up on our unit, in patients with cardiogenic shock, a cardiac index of 1.6 on average, this is I think 12 patients, we were able to increase it to 2.5. The patients were off all inotropes within 12 hours, and their measured GFR increased over that period of time. So it's much neglected. There are emerging small studies, but I think there are simple things that we can do using echocardiography on the ICU, and we should begin to investigate them more systematically. What I'm particularly interested in is this, though. There's a very nice study that was published in the Journal of the American College of Cardiology back in 2003. And what this study did was it looked at dobutamine stress echocardiography in different patient populations and looked at the response of the TIVT and showed that in certain patient populations, rather than shortening this and making the heart more efficient, where you give dobutamine, the heart becomes less efficient or fails to shorten in other groups. And it may be that the way we use our inotropes on our patients, we're able to measure what the patient's individual response to an inotrope is and minimize the potential harm by making the heart more inefficient. Very finally, and this is leading on to Holger's next talk, what about any other information? You've done everything you can, your patient's in big trouble, you're thinking about extracorporeal support. There are things that you will see on echo that you might think aren't relevant under normal circumstances. So, for example, on color M mode, this degree of aortic regurgitation is not that important. But if you put that patient on peripheral VA ECMO, what you will see if the heart stops ejecting is continuous aortic regurgitation and potential LV dilatation. So always think that if you're going to do something different, for example, as Holger's going to talk to you about percutaneous support, think that what might be okay in an ejecting heart may become very much not okay in a non-ejecting heart. And if people are thinking about other mechanical support, for example, a left ventricular assist device, if you have mobile thrombus at the apex of the left ventricle, that is a very important finding that you must communicate. So the take-home messages for everything you need to know: when you're approaching a patient on the ICU, know what questions to ask. So what do the intensivists want to know, and what can you tell them as a cardiologist? The second, which I think is very important, if your imaging is awful and you can't see anything, don't guess. Just say you can't see. Either do a transesophageal echo or think of another way of getting the information. If you don't understand what the intensivists are telling you, for example, they're trying to blind you with science about how they're ventilating the patient, ask them and ask them to explain. And finally, these are the sickest patients in the hospital. If you're not sure, if you're not absolutely certain of what to say, then you should ring somebody else and get a second opinion. And if you want some nice information and resources, we have available, we've got the paper that came out from jointly between the EACVI on acute cardiac care, echocardiography, and about to be launched at the end of this month. There are 12 courses within the ESC SCAL specifically on critical care echocardiography. Thank you very much.
Well, thank you very much, Susanna, for illustrating all the opportunities that acute and critical echo can give us. We will hold the questions for the end of session. So we move on now to the next speaker. He's Holger Thiel. So probably his name at least is so familiar to all of you. He's professor of medicine at the University of Lübeck. He's an interventional cardiologist, but for what he is really famous is because he's been the PI of the EIBP Shock 2 trial that actually changed the whole understanding of what we used to do in the management of cardiogenic shocks. He is also the PI of the Calvary Shock trial, and so we didn't dare to ask him to talk about IIBPs, so we want him to talk about the role of percutaneous ventricular assist device, which is a step farther on the management of patients. Holger.
Yeah, dear Héctor, thank you very much also for the invitation here to Spain. These are my disclosures. So I particularly try to focus on assist devices for patients in cardiogenic shock. And as you all know, so the early revascularization can reduce the mortality for patients in cardiogenic shock, as this has been shown mainly by the Milestone shock trial. And afterwards, we face this problem. So we have stunned myocardium, and this takes hours up to days until the recovery of the myocardium, until we will have a recovery in the left ventricular function. And this is something we try to bridge. We try to bridge it with inotropes. We also try to bridge it with vasoconstrictors. And this is the theory that we also can bridge this by using a percutaneous device. And as you can see, there are several devices on the market. In particular, for Europe, they are CE marked. So we have the IIBP, we have the Impeller family from 2.5, 3.5 up to 5.0. Then very recently introduced, we also have the HeartMate PHP. Then we have different devices, ECMO or ECLS systems. And we have the tandem heart, which is not so often used in Europe, which is mainly used in the United States. And then we also have a relatively new device, which is the IVAC2L. I will try to cover with you all the data we currently have for these devices, and then probably we will also have to discuss when to use them. This is probably the most important thing. So, okay, I also cover the intra-aortic balloon pump because our trial, our IVP Shock 2 trial, also led to an increase in the use of the other devices, as I will show you later on. Nevertheless, if we talk about the intra-aortic balloon pump, we will have to think about the hemodynamic effects, and we also will have to look for the data we have currently in cardiogenic shock. Just looking back into the hemodynamic effects, this is what you all have learned when you have been working on the ICU, even maybe as a student. So we have the diastolic augmentation, we have the assisted systole, so the blood pressure during diastole goes up and the blood pressure during systole goes down, which has been shown that we have an improvement in coronary perfusion, we have a reduction in afterload, and we have also a reduction in myocardial oxygen consumption. And if you look for this has been published in 1973. So this was a registry of the use of the intra-aortic balloon pump, and then they were looking for the hemodynamic effects. It's interesting to see that also this has been published in the New England Journal of Medicine in 1973. It's just a registry on a mechanical support device. As you can see, there's no effect on the heart rate. There's a decrease in the systolic blood pressure, an increase in the diastolic blood pressure. But importantly, and this is what we are currently using mainly in the intensive care unit, no effect at all for the mean blood pressure. And there was an increase of 0.5 liters per minute in the cardiac output. But this was only a registry and there was no control group, what we have to keep in mind. If we do this in a randomized fashion, this was the pilot trial for our trial, the IBP Shock 1 trial, looking for the cardiac output. You can see there's an increase in the cardiac output for patients with the intra-aortic balloon pump, and as well for those patients without any intra-aortic balloon pump. So this is the increase, which is mainly a result from early revascularization by optimization of fluids, by maybe optimization of inotropes. So this is no effect of the intra-aortic balloon pump. And then we also look for the mean blood pressure in our IBP Shock 2 trial. As you can see it here, there was an increase in the mean blood pressure after revascularization, but the mean blood pressure was absolutely identical for those patients with the intra-aortic balloon pump in comparison to control. Now looking for the data for the intra-aortic balloon pump in cardiogenic shock. This were the guidelines, the American guidelines, formerly up to 2012. This was a class 1 recommendation. This has been downgraded to 2AB, and this is still in place for the American guidelines. And in the European guidelines in 2012, there was a downgrading also from 1C to 2BB. And the reason for this was not our trial, but the reason for this was this meta-analysis, which has been done by a Dutch group, and they looked for all the data that were available for intra-aortic balloon pump in cardiogenic shock. There were no randomized data at this time. So if we do not do any reperfusion, there's a reduction in mortality with the intra-aortic balloon pump, according to registry data. If we do thrombolysis, which is also not beneficial or which has not been shown any beneficial effect for patients in cardiogenic shock, there's a reduction in mortality. But if we do evidence-based medicine, according to registry data, there's a 6% mortality increase. Taking all together, there was 11% mortality reduction. However, as you all know, these are registry data which are prone to bias, to selection bias, so we really do not know. And this was the reason also to say, okay, we do a randomized trial. And we had big problems. It took us more than a year to get final approval by the ethical committee, because these were really arguments which we got that we are not able to do such a trial because it's unethical to not put in an intra-aortic balloon pump in a patient with cardiogenic shock. This is another argument which we got. In the end, we were successful, because we had also some arguments, mainly based on this registry, on these registry data, on this meta-analysis, and then in the end, we got final approval for this trial. As already mentioned in one of the previous sessions, so there were 600 patients who were randomized. As you can see, only 190 were excluded, so altogether this is a relatively good inclusion rate altogether. And I always show this, although this is a secondary study endpoint, I was a believer of the intra-aortic balloon pump before. And I always thought, okay, if we are not able to show a benefit and mortality, at least we should see something in serum lactate. But as you can see it here, for a very sensitive parameter, there was no effect at all for serum lactate for the intra-aortic balloon pump in comparison to control. And not a surprise, there was no difference in 30-day mortality, although there were still some believers saying, okay, there's 1.6 absolute mortality decrease with the intra-aortic balloon pump. We look for this at 12 months follow-up, and then it's the absolute identical. So there's really no sign at all that any group or that the intra-aortic balloon pump can improve the clinical outcome. And we also had some crossovers, and that's the reason why we look for the as-treated population. As even if you look for this, there is no difference at all if we look for the as-treated population. So taken all together, you have seen this slide previously. So if we are talking about cardiogenic shock and acute myocardial infarction, early revascularization can reduce the mortality. So in case we need vasoconstrictors, according to a subgroup, a predefined subgroup of the SOAP2 trial, norepinephrine seems to be better than dopamine, but all the other treatment options, including the intra-aortic balloon pump, is absolutely neutral. There's no effect at all on mortality. So taking all these things together, as mentioned, I have been a believer in the intra-aortic balloon pump, but during all the review processes of our data, we looked under every stone. I personally believe nowadays that it's just a mechanical placebo shifting the systolic blood pressure to the diastolic blood pressure without any effect on other relevant hemodynamic parameters. And this is not a surprise. Now the ESC guidelines have downgraded it within 2 years from a class 1 recommendation to a class 3 recommendation for the treatment of patients with cardiogenic shock. And as mentioned, our trial had influence on the use of the intra-aortic balloon pump and also on the use of other mechanical assist devices. In the United States, it's more tradition to use the intra-aortic balloon pump. I personally was surprised to see there is a decrease of the use of the intra-aortic balloon pump, but this is only a small step down. In Germany, it's totally different. So we are using the intra-aortic balloon pump in really less than 10% of the cases for patients with cardiogenic shock. But as you see in the United States, it's going down, then it's going up once again. As you can see it here, there's an increase because this is a reflex, so the intra-aortic balloon pump does not work. So we have to use active devices. There's an increase, but if you look for this active assist devices are used in less than 10% of the patients. And most of the patients do not get any mechanical support, even in the United States. Now coming to these active devices, looking for the impeller, for the data for the impeller, also looking for the tandem heart. There's one, if you look for it, then it's very important to look for the hemodynamic parameters and also for the technical parameters, which is maybe important. You have to look for the cannula size, which is important to look for, and then you have to look for the flow. With the ECMO, you can achieve up to 7 liters per minute. With the tandem heart, up to 4 liters, or maybe a little bit more. And with the impeller, 2.5. You get 2.5 liters, 5.0, 5 liters impeller CP or 3.5. You maybe get a little bit more than 3.5 liters per minute. The new HeartMate PHP is a very interesting device because it has a relatively small cannula, and it can provide a flow of more than 5 liters. So from this aspect, so the cannula size and the flow, it's a perfect device, but the problem is it's currently only approved for 6 hours use, currently for high-risk PCI, and there's currently working on a trial to get approval also for the cardiogenic shock in Europe. If we look for the data, there are only a few data. There are 3 randomized trials that have been performed so far. Intra-aortic balloon pump on one hand side, versus an active device. The first 2 trials were trials with the tandem heart. The third trial was an impeller trial. You can see they do what they should do. They improve the cardiac index, they increase the mean arterial blood pressure, and they reduce the pulmonary capillary wedge pressure. So all beneficial effects. But we did an individual patient-based meta-analysis. So you can see it here, there's no effect at all on mortality if you look for these capillary myographs. But we have to keep in mind there are only 100 randomized patients so far. What we have to keep in mind, and this is maybe also one of the reasons why we do not see any benefit, because we have observed more complications, particular bleeding. In one trial there was also more fever and sepsis. Also in one trial there was more limb ischemia. Taking so pure evidence, taking all these things together, once again, active devices are not able to reduce mortality based on the limited data what we currently have with only 100 randomized patients so far. Which does not mean we should not use them, but we have to define when to use them. Now, a few words on ECMO. This is also a device which is increasingly used for patients with cardiogenic shock. There's only very, very limited evidence for the ECMO. There's one retrospective registry looking for historical data where a ICU had no ECMO, and afterwards when they introduced the ECMO, they look for the mortality for patients with ECMO and without ECMO, and so you see a tremendously decrease in mortality. However, we are not sure if this is an effect by the ECMO or this is maybe just an effect over time with improved treatment of patients with cardiogenic shock. There are other data from Paris where they have dedicated ECMO teams who drive out, put in an ECMO in tertiary, non-tertiary centers, and then they refer the patient to tertiary care centers. You can see these Kaplan-Meier curves, which are also very similar to that what we have seen in several other shock trials. And like always, you have to read in detail what is in the publication. So mortality for patients older than 62 years was 100%. And patients undergoing resuscitation also had a mortality of 100%. So this is what we have to keep in mind also for our selection of patients when we put in any active device. We also have very recently published a trial on ECMO for patients with cardiogenic shock, all kind of cardiogenic shock. You can see it here as well. So mortality is extremely high because this is the selection of the sickest patients with cardiogenic shock. When we decide to put in an ECMO, you can see so 84% mortality over time, which is extremely high. And also here, age played an important role. You can see patients older than 75 in this trial, they had a mortality of also 100%. So this is for our selection when we put in such an active device, a careful consideration what we should do. And also, if we are talking about ECMO, so the complications with the ECMO are relevant, as you can see it here from this meta-analysis. So you can see it here, lower extremity ischemia, 17%, even amputation in up to 5%, stroke, major bleeding, nearly a little bit more than 40%. This is what we have to keep in mind if we are using such devices for these patients. And there's a relatively new network meta-analysis looking for all the data for the comparison intra-aortic balloon pump versus medical therapy and percutaneous assist devices versus medical therapy or versus IVP, and you can see that the intra-aortic balloon pump has no effect even in registry data and also with randomized data. There's no effect of an active device in comparison to the intra-aortic balloon pump, even for early, late mortality. As you can see it here, so currently all the evidence we have, this is totally neutral for all the active devices. Nevertheless, we should still use them. And we recently did a review on how to treat patients with cardiogenic shock, and we tried in this scheme, in this algorithm, we put in all the guideline recommendations by the ESC. You can see it here, okay, we should do an invasive angiography, then we should look for the patient, we do revascularization. The intra-aortic balloon pump is out, so you should not use it anymore. But if the patient is in persistent cardiogenic shock, then you should consider an active device. First of all, a percutaneous one, and later on you should also consider looking for a surgically implantable device. The intra-aortic balloon pump is still in place, so it's a 2AC recommendation for mechanical complications, for ventricular septal defects, for acute mitral insufficiency. In this case, although there are no data, there's still a 2AC recommendation to use the intra-aortic balloon pump. And this is probably, I can't give you an answer, But this is the considerations what we have to do in patients with cardiogenic shock. We do not know when is the optimal timing for the implantation for a device. Should we do it very early at the beginning of cardiogenic shock? Should we do it very late? So maybe then we will have a futile situation. We also do not know what is the optimal support. We do not know if we need 2 liters, 3 liters, 4 liters, 5 liters. And we also have a problem with respect to the optimal prevention of potential complications. So if we would have a device without any complications, for sure we should put in an active device in every patient and as early as possible. But because of the complications, we also have to consider when to do it. Because the more invasive we are, the more invasive devices we are using, like for example the ECMO, the more complications we will also may encounter. And this is what we have learned, at least also from our IP Shock 2 trial. 60% of the patients will survive without any active device, or also without the intra-aortic balloon pump, if we treat them according to guidelines. We still have 40% 30-day mortality. In the IRBP Shock 2 trial, 5.5% of the patients got an active device. In these patients, mortality was 70% because this was a selection of the sickest. Not sure if the survival was introduced by an active device. But if you put in an active device in every patient, and I've seen these patients, you will also lose some patients because of the complications of the device. And that's the key question, the key issue in which patient we really have to put these devices in. Currently, there's one ongoing trial. That's the so-called Danish shock trial, the DAN shock trial, randomizing patients with cardiogenic shock and acute myocardial infarction to either the impeller versus standard of care, where they still allowed to put in an intra-aortic balloon pump, but they have a very slow inclusion rate, and so far I know they probably will not be able to finalize this trial. But this trial would be extremely important to get more information on when to use these devices. And this is the problem. So currently what we have quite a few recommendations. There's no 1A recommendation because we have not enough randomized trials in cardiogenic shock. So the shock trial, only 300 patients was able to show a significant reduction in mortality by early revascularization. So we did so far the largest randomized trial in Germany with 600 randomized patients. And currently we are doing the so-called Carpet shock trial, which is performed in Europe, aiming for 706 patients altogether, and we have included a little bit more than 420 currently, and we hope to finalize this trial within the next year, and then we hopefully will be able to give you the answer, what is the optimal revascularization strategy for those patients with multivessel coronary artery disease and cardiogenic shock. Thank you very much.
Thank you very much. Holger will leave the questions for after the last presentation. And it's a pleasure to present Professor Kostadinides. He's the director of the Centrum for Thrombosis and Hemostasis at the University of Mainz. He also holds the professorship of clinical trials, and he was the co-chair of the last ESC guidelines on pulmonary embolism. So, pleasure to have you here.
Dear Alessandro, dear Héctor, thank you very much, and many thanks to the working group on ischemic heart disease and acute cardiovascular care of the Spanish Cardiac Society for the kind invitation to this great conference in this great place. So we will now make a right shift, not politically, but to the right ventricle, and discuss a little bit acute cardiovascular care of the right ventricle, taken as an example, acute pulmonary embolism. I was also asked to give a very, I would say, overstated for myself lecture, state of the art in pulmonary embolism, and I decided to modify it a slight little bit and talk not only about what the guidelines say and what is the state of the art, but what the guidelines also do not say, or what questions remain unanswered, and we will probably or hopefully be able to address in the future guidelines. These are my disclosures. So I have written here a couple of topics. Do not be afraid, we will be ready in time. But we will start with the diagnosis of PE and ask the question, is everything is clear there? And if we have actually found the optimal algorithm for confirming the diagnosis in the patient with acute PE. Before I do that, I would like to give you an overview of what progress we have made, or maybe not, in the diagnosis and treatment of pulmonary embolism over the past years, over the past 10 years or so. So here you can see, this is from a recent overview on review on PE that we wrote for the JCC, and here you can see two different things. So the first thing is that incidence rates in several countries from population-based data, including Spain, appear to rise. So pulmonary embolism, or VTE, appears to become more frequent. On the other hand, case fatality rates appears to go down. As the result, mortality rates, this means the deaths per 100,000 populations due to VTE, do not go down. They stay stable, or probably they even go up. So this appears to be very good news. So we are doing better, less patients die of acute PE. But how do we explain this one? So here the explanation might be we have to do, it was addressed in the previous session, with an older population. We have to do with patients with comorbidities, patients who need to be operated, so more patients suffer PE. But this may also be due to another technical problem, which is unfortunately quite alarming. The problem is related to diagnosis, or perhaps overdiagnosis, of pulmonary embolism. This is from the European guidelines, which, as Alessandro said, I had the honor to co-chair together with Adam Torbitsky in 2014, 2 years ago. So, I mean, this algorithm appears to have been quite consolidated. By the way, algorithm is, unlike most words in medicine, not of Greek origin. It comes from the name of this gentleman, Muhammad al-Khwarizmi, who was an Arab mathematician who actually described the first algorithm about 1,200 years ago. So this algorithm for diagnosis of PE based on the CT appears to be quite stable and quite mature since 2008. So there appears to be little movement or change in this. You would say this is fine. We have optimized diagnosis of PE at least. And the only change in the guidelines with regard to 2008 in diagnosis was the fact that we included the data by Mark Rigini from the ADJUST PE study, a multinational, multi-center trial, in which it was found that to increase specificity, the D-dimer test used to proceed if a patient has lower intermediate clinical probability of PE can have a higher cutoff in patients over 50 years of age. So we usually, as you know, or we all use 500 nanograms per milliliter as the cutoff to define a D-dimer test as positive or negative. If the patient is over 50, we multiply the patient's age by 10. So for an 80-year-old, it is 800. And this increases the specificity. So this is clear, but there is also the thing that a positive CT confirms PE and thus makes us initiate treatment. And here is a potential reason for this finding, namely that we may be overdiagnosing PE based on single subsegmental PE, which is now, of course, increasingly being diagnosed with multi-detector row scanners. And you know that this is a difficult diagnosis in which the agreement between investigators, radiologists, is quite low. So you see, if you see the overall agreement between expert radiologists in diagnosing PE, so this appears to be quite easy and straightforward. But you can see, as we move from lobar to segmental and subsegmental level, this becomes very low indeed. So we may be overdiagnosing pulmonary embolism at the subsegmental level, and this is supported by the fact that although the rate of subsegmental PE has increased dramatically with the technical advances in the rows of multi-detector CTs, the rate of recurrence without treatment has not increased, which probably means that some of these PEs were not PEs, but they were artifacts or difficult diagnosis. And again, you can see from some studies which were not randomized studies, there appears to be almost no recurrence without anticoagulant treatment, against raising the issue that we may be overdiagnosing pulmonary embolism here, and thus we increase the incidence rates, which is bad news, and we also then artificially lower case fatality rates, because these are patients that have no PE, so we increase the denominator and case fatality becomes low. So at the moment, these are the most recent guidelines by the ACCP, January 2016, quite a pragmatic approach, no data. So if you have someone with subsegmental PE, so you just judge if the patient is at low risk of recurrence. We will speak about recurrence in the last 3 minutes. Then you should not anticoagulate, but if the patient is at high risk of recurrence, you should anticoagulate this patient. So this is something that makes sense, but this is eminence-based. There is no data on this. What is generating data, and what we will have hopefully until 2020, is the fact that there is now an ongoing study in which a management trial in which anticoagulation is withheld in patients with subsegmental PE. We speak of single subsegmental pulmonary embolism, and in whom serial compression ultrasound examinations of the lower extremities are done. So if they are negative, they withhold anticoagulation, and they of course follow the patients for 3 months or so, show who will have recurrences. So maybe we will have more data here on how to deal with these very difficult distal emboli that may not be emboli in the end. So what about intermediate risk? Now, this is an interesting thing, because defining intermediate risk has also been the focus of our research in our group for 25 years now, and we believe that we have reached quite a nice consensus on that, and we say, of course, the first thing is to say, is the patient in shock or is the patient not in shock? This is the first primitive, let's say, distinction, and this is very clear. And in patients not at high risk, we put a clinical filter, because we do not want to send every normotensive patient to the echo or every normotensive patient to do a biomarker test. In cardiology, this is not a problem, but pulmonary embolism is a transdisciplinary disease, so many pulmonology colleagues said this is not acceptable, or vascular physicians. So we have to have a filter, have to take out some patients who are at low risk and do all the rest, send all the rest to the echo. So this appeared quite reasonable, and there is this pulmonary embolism severity index, and of course you know very well that also here in Spain many colleagues from pulmonology, David Jimenez, most of all have done a lot of great work, epidemiological work on the PESI and the SPESI, but things, unfortunately, for the non-cardiologists, so it's good here, but it's not very good to say outside, are not so simple. So there are cases, on the day that the guidelines were presented, on that same day, this case was presented at the ESC Congress, in which a young man presented with dyspnea. Pulmonary embolism was diagnosed, and this was the case of a man who is not in cardiogenic shock. He has some tachycardia, he has some marginally low blood pressure, he's 30 years old, he has some tachypnea, and he has some hypoxemia, but none of them is really severe. So this patient, who has, by the way, a pathological high sensitivity troponin test, just because, he had some chest pain, and of course the first thing that is done is always the troponin test before physical examination, right? So this patient is not in shock, but if you look at the PESI of this patient, he has a PESI of 40, which is low risk or very low risk, and he has an SPESI of 0. This patient had this echo, right, which I believe is very clear that it has a D sign and is a site of acute right ventricular failure. So here, I'm not so sure that this is a low-risk patient. And Dr. Price talked to us elegantly about echo in acute cardiac care. I would like to say that with regard to acute right ventricular failure, this is from a consensus statement that the Heart Failure Association, together with our group on pulmonary circulation and under the guidance of Dr. Harjola, published a few days or weeks ago, and in which we summarized, among others, some of the signs of right ventricular failure. And where you can see in acute PE, there is unfortunately, in contrast to pulmonary hypertension, no clearly validated set of parameters of acute right ventricular dysfunction. What we mostly use is the RV-LV ratio. We use the D sign, so the paradoxical septal wall motion or the flattened septum, and of course the inspiratory collapse of the inferior vena cava is a very helpful, simple sign. We can discuss this later with our expert echocardiographers, but historically these are the three most frequent parameters. Other parameters, I mean, like TAPSI may be helpful, and other parameters have not really been validated for acute right heart failure due to PE. So our patient had this finding, and he had this CT with an this is RV-LV diameter of 2.67 and a positive troponin. So it's not so easy just to do the clinical score and then say the patient is at low risk and there is no problem with the right ventricle. So here we still have a small gap in our knowledge. We will need to explain, to do this algorithm perhaps a little better. Maybe it's not an algorithm in the end. Maybe we need to do this assessment of the right ventricle and the clinical score together at the same time and not stepwise. So this is the second problem we have right now in 2016 after our guidelines. I would recommend, at least in a cardiology congress, to always look at the right ventricle, and it's not so difficult after all. If you do not want, or if you cannot do an echo, you can always look at the right ventricle on the CT and have a first impression. And as I said, cardiac troponin test is something that is done as the first test before inspection of the patient anyway. So, the other thing is about reperfusion treatment. I mean, we're talking about acute cardiovascular care, and we had a lot of discussions. This is a discussion, a debate that has been similar to the one presented by Dr. Thiele regarding the shock treatment. So here in intermediate high-risk PE, so the patients who have clear signs of right ventricular dysfunction, we've also had quite a debate of almost 40 years. Should these patients be thrombolized or should they not be thrombolized? I mean, everybody thrombolizes cardiogenic shock. It's also this parachute and randomized trials example. I mean, you have to do something about this, these patients, but these are fortunately only 3% of the patients with acute PE anyway. So these are about 10 to 15%, and what do you do with them? If you look at meta-analysis are a very nice thing and can really generate nice papers. So we did a meta-analysis of thrombolysis studies in PE. We did identify a number of studies, and generally you would say, well, in trials that, these are all trials, they are not registries or cohort studies, in trials that included patients at high risk or intermediate risk, well, it's not definitely conclusive, but thrombolysis appears to be positive, beneficial. But as you know, in the Python trial, in which we included 1,005 patients in 13 countries, we found that in these patients, the normotensive patients with intermediate risk PE, thrombolysis is effective. It reduced the primary efficacy endpoint from 5.6% to 2.6% at 7 days. So it appears to stabilize the patients hemodynamically, but the price to pay was too high. 2.4% patients with stroke following thrombolytic treatment, and these were hemodynamically stable patients, at least apparently stable patients, is of course not acceptable. So we do not have a problem of efficacy, we have a problem of safety. And this is why the guidelines have been changed here, and now in intermediate high risk, so in high risk PE, in the lack of a lot of data and in the lack of a better option, we do still recommend a primary reperfusion, mainly full dose systemic thrombolysis, but in these patients with intermediate high risk, thrombolysis has a class 3 indication now. It is no longer indicated as a first-line therapy, but monitoring is indicated for 2 or 3 days, and if the patient decompensates hemodynamically during this course under effective anticoagulation, then thrombolysis can be given as rescue therapy. So this has been changed, but the question remained, if well, if thrombolysis works, then we should find a way to make it safer, because, as I said, the efficacy problem does not appear to exist. In the United States, unfortunately, I would say, Dr. Thiel and I had a session at the ACC last year, and I mean, with regard to, I mean, you were not talking about PE, but with regard to PE, there was this debate, shall we give half-dose thrombolysis? I mean, as you know, in medicine, half dose of the drug is a very nice thing. We give half dose of beta blockers in heart failure, half dose of ACE inhibitors. So you've thought of the drug, but you've not given the full dose. It's safe. And in pulmonary embolism, there's the idea, which is unfortunately popular, as I said, because it's not evidence-based, that half-dose thrombolysis might work. It is mostly based on a cohort study, which was baptized a randomized trial. It was not. And the cohort study by Dr. Sharifi in the US found out of 121 patients that half-dose thrombolysis in moderate PE may reduce the rate of pulmonary hypertension over the long term. This was also quite impressive that 60% of patients who were anticoagulated had persistent pulmonary hypertension, which is really a huge number. So anyway, the data in favor of half-dose thrombolysis are not sufficient. There is now some preliminary work being done to create to activate the network again and test thrombolysis in half-dose, but until then, this is not an option, a really scientifically recommendable option. What also, of course, has emerged in the past years and continues to become increasingly popular is catheter-directed treatment, pharmacomechanical thrombolysis. This is the FDA-approved and also with an EMA sign, CME, the ECHOS catheter, which is a catheter of mixed thrombolysis, so it's a multi-side hole catheter for administration of low-dose local thrombolysis in the pulmonary artery, along with emission of ultrasound. The ultrasound is supposed to penetrate the thrombus and make it more permeable to the thrombolytic drug. This is the principle, and this is from the Swiss group in Bern, from Niels Kucher's group, that thrombolysis by this catheter. There are two catheters, one in each pulmonary artery, which doubles efficacy and also the price of the procedure. And you can see here that you have thrombolysis of the left and the right artery, and this is quite sufficient. The follow-up is after 24 hours. Full-dose systemic thrombolysis already works at 2 hours. We don't know if the device is fast. What we do know is that this method does not massively decrease overall bleeds. So you see that gusto major bleeding in the Seattle 2 study, a cohort study in the United States recently published, was still 10%, but intracranial hemorrhage, because we're giving only 1/5 of the dose of the thrombolytic we would give intravenously, appears to be very low, if not zero. So this is good, but there are a number of issues that continue to exist with regard to this method. So we cannot yet say definitely that, that this will become the standard method, but certainly it has some data. The quality of the data is okay for an interventional method in PE, and it can be used if it is available, and if the hospital can afford it, it can be used as an alternative to full-dose thrombolysis in a patient who has a high bleeding risk, and the physicians believe that he is decompensating and he must be treated with some reperfusion treatment. So apart from that, the guidelines unfortunately cannot or give very little on very sparse guidance on how to manage the acute right ventricular failure in general. And this is also I think it was also a good idea that Dr. Hargela, Dr. Bueno, and others, the large group, we had this position paper, which I believe quite practically summarizes what our current state of knowledge is regarding the overall treatment of right heart failure. So not the specific treatment of PE, but how do you treat acute right heart failure? And you can see here, and you can see here the steps from identifying of triggering factors, which we spoke about, optimization of fluid status, the maintenance of arterial pressure with norepinephrine, consider inotropes reducing filling pressures, and further measures for afterload reduction, and of course assist devices or ECMO devices, which tend to become more simplified, also may have a place in acute pulmonary embolism treatment when there is overt right ventricular failure, so apart from reperfusion treatment. Now, in the last 5 minutes, I would like to, because this is not directly related to acute cardiovascular care, but pulmonary embolism is a disease that causes acute problems, but then also leaves significant issues for many patients over a longer period. And so there are 3 brief questions to be handled. First of all, can some patients be discharged early within the first 48 hours and treated at home? Is there something like low dose or low risk PE? The guidelines say, again, as I said, I mean, my enthusiasm for the PESI score is diminishing in the past 2 years since the guidelines, but in the guidelines we said, okay, low risk patients may be considered for home treatment. And this appears reasonable, but when we look at the data, there are some studies that have been performed in the past 5 years. They generally showed that mortality, recurrence of VTE and all-cause mortality are quite low if selected patients are treated at home, so it appears to be feasible. But actually, the vast majority of these trials, except for one single trial, did not use the PESI to select patients. So we are now conducting a large single arm phase 4 trial trying to recruit 1,050 patients. We are still in the beginning. We have about 200 patients in whom we select patients with acute pulmonary embolism based on criteria of low comorbidity status, hemodynamic stability, and of course a social and family background that supports home treatment. And of course we also demand absence of acute right ventricular dysfunction, and then we treat those patients, we send those patients home and treatment with a new oral anticoagulant, rivaroxaban. We're actually going to initiate and involve Spanish sites very shortly in this trial. It's an academic trial, not an industry-sponsored trial, and I think we will be able to address also the issue not only who is the most severely ill patient, but also who can, on the other hand, at the other hand of the severity spectrum, be treated at home. So the question is, we start anticoagulation in all patients with PE, regardless of whether we need reperfusion or not, regardless of whether we keep them in the hospital or send them home. But the question is, what is the optimal duration of secondary prophylaxis? 3, 6 months, 1 year, 2 years, forever? The answer is we do not know. The guidelines just repeated what had been said in the past for patients with unprovoked PE, which means without reversible factors such as surgery or trauma or pregnancy. Oral anticoagulation is recommended for at least 3 months, and after that you evaluate the patient at regular intervals, and if possible, you continue. Now, of all the factors we know about recurrence, the strongest factor that influences our decision is, as I said, if the PE event, the first event, was provoked or unprovoked. If it was in the presence of a risk factor that is reversible, then we will stay to the 3 months. We will not anticoagulate forever. But if the risk factor was not reversible, I mean, all pulmonary embolisms are provoked by something, so maybe provoked is not a very nice expression, but if it has been provoked, if it has not been provoked by a reversible factor, we would tend to anticoagulate longer. And this is just to show that also biomarkers at some intervals after PE, just as the D-dimer levels that some physicians do not appear to really help. This is the most recent study from Canada by Clive Kieran's group, showing that actually, particularly in men, if you have a high D-dimer levels 6 months after treating the patients and after stopping anticoagulation, this is a sign that you should continue anticoagulation. But unfortunately, if the D-dimer levels are low, the patients are not protected. They may still have recurrence. So there is no true parameter and no recurrence score at the moment, externally validated recurrence score, to tell you that you can stop anticoagulation. So generally, if at all possible, based also on the bleeding risk and on the tolerability of these drugs should be continued forever, because as I said, as soon as the drugs are stopped, this is 2 years after treatment, so 18 plus 6 months before randomization, recent study by Coutureau in JAMA, immediately recurrence risk starts again. No safe point to stop anticoagulation. So we will see if in 2020 we will have more data on this. And as a last word, for 1 minute, the thing that what is the care of the patient after PE? We do not know how long to take care of these patients. We would think that patients who are anticoagulated may have the risk of recurrence, as I showed you, but otherwise they recover quite well and they are fine. But there is this pathophysiology, the presumed pathophysiology that leads to chronic thromboembolic pulmonary hypertension. So from acute PE, in some patients, there may be defective thrombus resolution. There may be a progressive vascular occlusive disease, this CTEPH, which is, of course, a disease with catastrophic consequences for the patient if it is not recognized and treated properly. Now, data from CTEPH show that VTE, previous VTE, so including pulmonary embolism, appears to be one of the strongest, especially if recurrent, one of the strongest predicting factors for the disease. So it is supposed to be a late complication of PE. And when it occurs after PE, it occurs from a long time after the index PE episode, as you see, up to 10 years after the index PE episode, we may have this complication. So this means the patient may need to be followed over the long term and not just for half a year or so. The disease can be diagnosed or treated, but the question is not how we treat or diagnose CTEPH, but how and if we have to screen patients after the acute episode is over for CTEPH, after pulmonary embolism. And this is an unanswered question that the guidelines also did not or could not answer, because as you can see from cohort studies reported until now, you have CTEPH rates after PE between 0.5% and 9%, which is a huge difference. And this means we do not really know how often this disease occurs after PE, and this is why the guidelines at the moment say, this is not very satisfactory, but this is the best we can offer. In patients who have survived PE and who report persisting or worsening symptoms like dyspnea, functional impairment, CTEPH should be sought and suspected and diagnosed, or the diagnosis rejected by full diagnostic workup, but screening of asymptomatic survivors after PE is not recommended at the moment because we are not sure that this is frequent. And this is again an issue in which we are conducting a large multi-center study to see what signs of progressive hemodynamic improvement can lead us to CTEPH after PE and which patients may be the candidates. We hope that these studies will all be ready and published by 2020 so that we will hopefully be able to answer more questions on the management of acute PE and its sequelae. Thank you very much.
Thank you very much, Stavros. Now the session is open for discussion. If there's any questions or comments from the audience.
Any tweets?
Okay, please.
I was just wondering if there is a severe pulmonary embolism. Why not send the patient directly to surgery who could fix the problem right away? And of course, there is sometimes some right heart failure, but it could be by an ECMO easily handled, and usually the patients recover well. If you do these lysis therapy, we do see more and more patients with these end stage of thrombi in the pulmonary artery, which is a tough operation compared to a simple embolectomy.
So, thank you. This is a very good question. What I would like to say is I know only one center in Germany where the surgeons are extremely eager to perform surgical embolectomy for acute PE, and this is unfortunately our own center at the University of Mainz. The thing with surgical embolectomy is, I mean, it is a valid option, there is no question about this, and it is of course an option that has not been validated in randomized clinical trials, but of course we cannot apply the standards of medical treatment to acute emergency surgical embolectomy. I think the issue is, if we have a patient who is in hemodynamic collapse, then this is an alternative to thrombolytic therapy, but of course the surgeon tells us this is now already too late. I mean, the patient's prognosis is bad, so it is an alternative option. But of course, as I said, thrombolysis is much easier to do. Thrombolysis it can be done everywhere and not in selected centers where a cardiothoracic surgeon is there. So this is, and for the other patients who are stable but are in the intermediate high risk category, it can be, and this is what we write in the guidelines, it should be considered in patients who have a high bleeding risk under thrombolysis. So thrombolysis is easier to administer. Perhaps the interventional form, or in the future perhaps low dose thrombolysis is safer. And of course, as I said, can be given everywhere. And surgery is an option, but surgery is open heart surgery. I think if we can come along without surgical treatment, this will also be good. So I would not say that this can become first-line treatment. It has no evidence, and I do not think that it can become popular. It can also not be given to everywhere. And what certainly cannot and should not be done would be to transfer patients with acute PE to another center, out of the far from the center that has been where the PE has been diagnosed, to be operated elsewhere. We have had some catastrophic events with this. I mean, patients had a huge relapse underway. So surgery is one of the alternatives to medical treatment, to thrombolytic treatment. It can be done if there is a team. In the United States, there is more coordination right now between surgeons and interventionalists and internists on how to treat acute PE, and there maybe they can find a consensus on how to treat a patient. But overall, it cannot be the first-line treatment in PE. And by the way, embolectomy, either medical with thrombolysis or with surgery, it has never been shown. And I can tell you from data, our own 2-year data from thrombolysis will be presented at the ESC Congress in a couple of months from now. But I would say I would not be very optimistic that this has anything to do with reducing CTPH rates over the long term. It's not so easy.
So if I may, because my question actually was going to be very similar, but with mechanical reperfusion, but because I think it's less aggressive than surgery in a patient and hemodynamic and unstable. So let me, because you mostly mention it, it seems you're not very convinced about the future of mechanical reperfusion for pulmonary embolism. But for instance, if you had a patient on cardiogenic shock with contraindication for to fibrinolysis, would you ship that patient to a center with primary, like a primary PCI strategy, a patient to a cath lab to do mechanical reperfusion?
So this would really be in acute pulmonary embolism. There is only one surgical center that claimed that this works. This was Dr. Ashlock, who was in Boston. You mean also with pharmacomechanical?
Mechanical with catheters.
This cannot be compared like this, I must say. I think this is far too dangerous. The thing is, if this is an acute case, and the patient has suffered PE, he has now been put on anticoagulation, and we have actually an acutely overloaded ventricle, I think the risks for transfer of this patient are too high. at the moment from what we know. So unfortunately, it is not so analogous to myocardial infarction. It would be nice if it could be. And maybe in 10 years from now, we can show that pharmacomechanical intervention can work so nicely and faster, because until now we know it works within 24 hours, 48 hours. I don't think this is enough. But if we can show it works fast, and if we can show it becomes easier and widely available, it might become an option. But at the moment, I would say we are very far away from this.
So you wouldn't transfer it, but if in your hospital, if you have this patient which is very sick and just contraindicated, you would go to send it to the cath lab.
These patients are either operated, so at the moment most of them are operated, but they can be treated also interventionally, yes. Okay. Whatever is, let's say, the mainstay of treatment, but I would see it as an alternative to the simple treatment of thrombolysis at the moment, or if there are risks and caveats.
Thanks.
So I think we have time for a couple of more questions. I have one for Susanna, and it's about the right ventricular function. You've been the co-writer for this recent consensus on right ventricular failure. So how good is TAPSI really with this patient? I mean, let's say I have a patient with an acute pulmonary embolism, and I'm not an expert, and I can do all those fancy things about strain of the right ventricle, and I want to keep it simple. And so what can I do?
Okay, it's right ventricular function assessment acutely is challenging. What we're learning from studying patients with severe acute respiratory failure and looking at the electromechanics of the right heart when you ventilate them, using an esophageal balloon as well to measure the intrathoracic pressure, you can make the right heart fail depending on how you ventilate them. So it's slightly different from pulmonary embolism, but the mechanism that the right ventricle seems to fail in if you increase afterload is that the duration of systole gets longer. The contractility of the right heart and its long axis in the first instance begins to drop, and then you begin to see right ventricular dilatation, which is relatively late. And the paradoxical septal motion, again, is a relatively late change. If you just rely on one single parameter to measure the right ventricle, and I think this is very clear from the pulmonary embolism data, you will get things wrong repeatedly. So you can't just say the long axis function or the strain or the pulmonary artery system.
Give me three good ones.
So what do I do practically on my ICU? Usually the image quality to use strain rate imaging is inadequate to get meaningful data. And if the right ventricle is very poor, you won't get anything that's sensible. So I use a combination of the long axis function of the right heart. I look at what the pulmonary acceleration time and the ejection time is. And I will take into account very much what the pulmonary artery systolic pressure is, either measured from echo, which will underestimate it if the TR is very severe, or by using invasive monitoring. So those are the things that I would do.
Okay, thanks. That's a good answer. And I also have one question for Holger, and it's about, now, we're talking a lot lately about these networks for treating patients with cardiogenic shock. So I'm not talking about your hospital or my hospital, where we routinely treat patients with cardiogenic shock. I'm talking about, let's say, smaller hospitals that don't have a lot of experience with devices, and maybe they have a cath lab. So what would be the ideal device to transfer patients for these smaller hospitals? Would you go for ECMO? Would you go for Impella? I know it's a challenging question. But
it's a challenging, difficult question for sure. The problem with that is, so if you have a smaller hospital, even if you have a bigger one, you will have, this is my personal opinion, you will have to decide which device you want to use. Even if you have a team of maybe 7 or 8 interventional cardiologists, so even if you have maybe 30, 40 cardiogenic shock cases per year, or maybe even more. So this will mean that every interventional cardiologist will implant any of these devices 3 or 4 times a year. And if you have different devices, so this will for sure lead that that the setup for the device will take longer, that there may be some problems also in the use, in the running of the device. And personally, I believe that you should restrict it to maybe one or maybe two devices. So you should not think about all pathophysiological considerations. So this device may be better for left ventricular dysfunction, for this may be better for a severe left ventricular dysfunction. Personally, I believe you should have a team which is familiar at least with one device, and then you may consider to go for two. But personally, I believe it makes no sense that you have 3-4 different devices.
Yeah, well, I think Alex's questions comes to the discussion that we have now nationally about these referral, cardiogenic shock referral centers, whether, it's just impossible to have left ventricular assist device all over the place, even in many big hospitals, it would be difficult. So we've been discussing about creating these networks. For instance, you have it in the UK. But the question is, would you think that actually the wisest approach is to have this network, is shipping all viable, I would say, cardiogenic shock patients to these centers, or wait until see how they're developing? Because you see roughly half of the patients would improve, but it's very difficult to predict in many cases. And then, because when they're really sick, then transfers are become very challenging. So what would be your advice in terms of how to set up, let's say at a national, regional level, a network system for cardiogenic shock?
Also a difficult question because we have no data for this. So intuitively, I would say, okay, so if you have an emergency physician, so if you have an ambulance system, that all cardiogenic shocks should be transferred to tertiary care center, which has the opportunity to put in an mechanical cardiac support device. So, but as we also know that approximately maybe 30-40% of the patients develop cardiogenic shock after hospital admission. For these patients, I personally believe that they should be transferred to these centers. If we always need a device which should be in place for the transfer, I'm not absolutely sure. So maybe for the sickest patients. So we also have, in Germany, we have we have regional networks, we have the same. So in case there is a problem in one of the smaller hospitals, so we send out a team, put in an ECMO, and then transfer the patient, which is also because you need lots of people doing it. So you have to, you need people on call. You need perfusionists to do this, and this is also for 10 cases a year. So this is quite a lot of effort you have to put in if you have such a system.
Thank you. So the last question for Susanna. You showed a very nice case. It's very sophisticated echo, but we have these, I would say, the different situation with everyone wants to do their echo in the emergency department, in the intensive care unit. So everyone wants to do their own echoes, but you have this super sophisticated echo. Even, for people like many of us that have been working, even we wouldn't even understand what some of the indices that you have shown. What is the right balance between, let's say, opening the availability of fast echo, intensive echo, and this, I would say, really directed, focused critical care echo?
It's a very politically challenging question to answer. I think that if you have a patient who is dying in front of you and you are trained to do focused 2D cardiac ultrasound as a rule in, rule out, as have been recommended by the guidelines on resuscitation, provided you're appropriately trained, provided you practice your echo within a governance structure that is appropriate for your hospital, so you have your echoes checked and your diagnosis checked, that we know is a safe and appropriate thing to do. But I think when people step beyond that and think they'd like to do a little bit more echocardiography, then it gets very dangerous because they don't know what it is they don't know. So in the UK, certainly we've taken the view that, fine, anybody who is trained appropriately can do focused cardiac ultrasound within the context of a cardiac arrest, provided there is nobody better trained immediately available. However, if there's somebody immediately available who is better trained, they are the person who should do the echo. And once you step into critical care echo, that there's this sort of concept that you can assess contractility and volemic status, and it's easy. Actually, I think it's some of the most difficult echo that we do. So we're really against people dabbling in echo and playing it, and very much you should be trained and then recognize that even if you are accredited in echo, that actually is the basic level to be able to perform echo independently. It doesn't make you an expert.
Thanks for your answer. I think it was very polite. We can discuss it privately. And we have a coffee break right now. You have 20 minutes for whatever you need to do. And then everyone back here for some very exciting clinical cases where we have our distinguished faculty, Susanna Price included, discussing these clinical cases.